Good morning, dear colleagues and guests. A very warm welcome to all of you here at the plenary session of our forum, Sociology of Health, Humanity and Technologies as the Key of Trust. We chose to focus on this particular topic because it could not be more relevant than it is today. Our discussion will center on a crucial question: how rapid technological progress affecting our core humanity, and specifically the trust and empathy that form the bridge between an individual and the healthcare system. The truth is, we are all living through a profound shift called a new digital revolution. And what we are witnessing is not merely a technical upgrade, it's a transformation that is making healthcare more technological, more organized, and rich with data. But beyond that, it is actively reshaping every single relationship within the system, between the patient and the doctor, and among all many participants involved in this complex process. And there are plenty of those. We know that over the past few years, artificial intelligence and health technologies have become the fastest growing markets. We are seeing an unprecedented integration of telemedicine, mobile health devices and digital diagnostics into healthcare at a remarkable speed. But this raises a fundamental question. Do these advances automatically lead to greater trust? Do they make people genuinely healthier or happier? And how can we measure that change in well-being? At the same time, we are observing a clear digital divide. There are those who are comfortable with technology that can actively engage with, for example, telemedicine. And then there are those who, for various reasons, are just not ready yet to use digital tools to manage their health or communicate with a physician. This divide itself is a critical factor in this trust equation. To add another layer, global research tells us something striking. On average, a physician interrupts a patient and begins steering the conversation after just 11 seconds. So we must ask ourselves, what impact does this have on building a trusting relationship? How could technology, sometimes seen as impersonal, actually help us reestablish a more positive and attentive connection and communication between the patient and the doctor? This is exactly where the power of sociology becomes indispensable. Our field provides us with methodologies to measure those very concepts: trust, empathy, human connection. It allows us to move beyond assumptions and truly understand the behavioral patterns of both patients and healthcare providers. We can analyze the patient journey, assess health literacy, and see how data flows influence every interaction within the healthcare system. That is why we gathered here today at Russia's largest national forum dedicated to the sociology of health. Our goal this year is to delve deeply into finding that essential balance. Not a compromise, but as a true synergy between human-centered care and technological innovation. And we aim to explore this vital role that sociological research must play in guiding us towards that future. We have a rich and demanding program ahead. Following this, we have several thematic discussions scheduled throughout the day. This plenary session will feature insights from a distinguished panel of experts who I will introduce. And tomorrow our focus will shift entirely to the practical application of sociology, which is evaluating healthcare systems and improving the crucial dialogue between patients and providers. Our schedule is very tight, so I suggest we proceed without delay. It is now my great honor to invite our first distinguished speaker to deliver the opening address, Mr. Batyr Berdyklychev, the head of World Health Organization office in the Russian Federation. Dear participants, dear colleagues, on behalf of the World Health Organization, allow me to welcome you to this forum. It has rightfully become a vital platform for expert discussions on utilizing sociological research in healthcare governments. We live in an era of rapid technological and social change. We must acknowledge that the traditional 20th century architecture of healthcare systems is lagging behind technological progress and no longer meets the needs of our populations. The integration of digital technologies, artificial intelligence, and new methods of diagnosis and treatment has become an undeniable imperative. It is essential for enabling our healthcare systems to respond to contemporary demographic challenges. However, this raises a crucial question. How do we preserve humanity in healthcare? How do we preserve humanistic values and patient-centered focus? This is precisely why the theme of today's forum is so relevant. Less than a month ago, Copenhagen hosted the 75th session of the WHO Regional Committee for Europe. Health ministers and delegates from 53 member states adopted the second European program of work, which sets out strategic priorities. One of those core priorities is harnessing innovation for public health. A corresponding strategy on digital health was also endorsed by the Regional Committee. The goal of this strategy is to steer technological progress toward the benefit of the people, to ensure equitable access to innovation, to strengthen health systems, and to build public trust. At the heart of the system lies the individual, their health, their rights, and their dignity. The strategy emphasizes three key principles: innovation for equity. Technologies must bridge, not widen, social and regional divides. Innovation for resilience. Digital solutions and new approaches must strengthen health systems, making them more agile and prepared for future challenges. And the third key principle is innovation for humanity. Every implementation must account for cultural, ethical, and social contexts, ensuring that healthcare remains humane and patient-centered. Here, sociology plays a pivotal role. It helps us understand how people perceive new technologies. It shows us how these tools affect trust in the healthcare system, the physician-patient relationship, and social justice. Without this understanding, it is impossible to build a sustainable and humane healthcare system for the future. Dear colleagues, our task today is not to pit technology against humanity, but to find a balance where innovations serve people and not the other way around. I'm confident that today's conference will serve as a platform for constructive dialogue, the exchange of experience, and the pursuit of solutions that will help us harmonize scientific progress with humanistic values. I wish all the participants a productive discussion, thought-provoking discussions, and fresh new ideas. Thank you, Batyr Berdyklychev, for these warm and inspiring opening remarks. I'm confident that our discussion today will be equally positive and yield significant results for all of us here. Now, I would like to invite our next speaker for the welcome address, Vyacheslav Lokosov, corresponding member of the Russian Academy of Science, director of the Institute of Socio-Economic Studies of Population, vice president of the Russian Academy of Social Sciences, and vice president of the Union of Sociologists of Russia. I would like to add a personal note here. He has been a tremendous partner to our work. When we first made the decision 6 years ago to establish a sociology center within our institute structure, it was his institute that provided us with crucial support. This support came in the form of expert personnel and substantial collaborative projects. So this partnership has played a major role in our center's growth, and today it is the largest institution in the Russian Federation focused on socio-humanistic research into healthcare system development and public health assessment. Our colleague Ignat Bogdan has been leading the center from its inception, so please, the floor is yours. Esteemed participants of the 7th Forum, Sociology of Health. Today, as you are well aware, the demographic challenge is rightly considered the most critical one for contemporary Russian society. This demographic potential rests on 4 key structural pillars: gender, age, ethnicity, and health status. It is evident that without a foundation of physically healthy people of reproductive age, any project aimed at overcoming this demographic crisis would be fundamentally utopian. In modern Russia, substantial efforts are being made to improve the population's health. We are seeing important positive shifts. For example, over the past 30 years, infant mortality has decreased fourfold. Furthermore, the trend is also improving in many indicators related to social health. We are observing a decline in mortality from digging causes and a reduction in alcohol consumption. It is also encouraging to note that a healthy lifestyle is increasingly becoming a part of the mainstream culture for Russians. The theme of this forum is dedicated to finding out the optimal balance between humanity and technological advancement. It is well known that one of the most foremost directions in technology today is the biological sphere, which is intrinsically linked to human health. It is entirely possible that these new technologies will help us find pathways out of the demographic challenges we face. There is a lot of debate right now about artificial intelligence, ranging from its role in pharmacology and extending healthy life to almost sci-fi transhumanist projects that push these issues into the realm of bioethics. I must emphasize an important principle. Our shared inspirations and good intentions must be grounded in scientific evidence. This includes fundamentally the perspective of the social sciences. We must ensure that the social cost of innovation does not reach a critical threshold that could lead to unforeseen and serious consequences. I'm sure that our work at this forum will help us find answers to this pressing question. For over 5 years, our institute maintained a close and productive collaboration with the organizers of this forum, namely the Research Institute of the Moscow Healthcare Department and its director, Doctor of Economic Sciences, Elena Ivanovna Aksenova. The sociology of health serves a vital function. It creates a feedback loop between the patient and the medical system, effectively helping to define the formula for trust between them. Together, we conducted a number of significant joint studies, including sociological research on healthcare staffing, mentorship programs, and healthy lifestyle promotion, and I sincerely hope that this collaboration continues. While projects focused on balancing humanity and technology are undoubtedly important, we must remember that societal trust is not automatic. Society will not place its trust in innovation if we lose sight of the social, historic, and continuity of our core systems, our education, our science, and our healthcare. Building that trust also requires actively shaping an informed public discourse. I am convinced that the work of this forum will make a substantial contribution to that public discourse and to crystallizing the essential formula for trust. I wish you successful discussions. Thank you. Thank you for your kind words, Vyacheslav Veniaminovich. Today we will be talking a great deal about the balance between technology and the human element in our society. And where better to start than with digitalization and the dynamic changes taking place right here in Moscow. I think it's fair to say that Moscow has become the undisputed leader in digital healthcare in Russia. And I believe that we have a strong case to make on the international stage as well. To kick off our discussion, I'd like to introduce our first speaker, Andrei Alexandrovich Chizhelnikov, Chief Specialist in Primary Medical Care for Adults of the Moscow Healthcare Department and Chief Physician of City Polyclinic number 220. Andrei Alexandrovich is at the forefront of all major digital transformation projects in Moscow's polyclinics. His work involves big data, managing large teams, and a crucial responsibility, ensuring effective collaboration within the healthcare system among doctors, nurses, and all staff, while also building a productive dialogue between patients and physicians through digital means. So, Andrei Alexandrovich, my first question to you is this: through which digital tools in your experience have proven to be the most effective in creating this dialogue? Thank you so much, Elena Ivanovna. First of all, it's a pleasure to greet you all at this event. It is true that our Sociology of Health Forum is indeed becoming perhaps the most crucial platform for discussing precisely that balance between the interests of patients and healthcare professionals. And this balance is truly only possible through the constant collection of feedback. As you were just explaining in your introduction right now, how vital it is to maintain the so-called equilibrium with digital technologies, it immediately occurred to me how interesting it would be to present on the topic of how our very information system has transformed since its inception. The HIMEAS system has been in place since 2010, 2011, and over this time it has undergone a colossal evolution. Importantly, this massive transformation is also the direct result of continuous public discourse, feedback from medical professionals and feedback from patients as well. This aspect truly is of the utmost importance. Today we can state with certainty that this is one of the world's leading tools for facilitating the delivery of medical care. And these are just not empty words. It's a system that truly enables us to operate on two critical levels simultaneously. On one hand, managing the enormous scale of our patient population, and on the other, allowing a highly personalized approach to each and every individual. I'd like to highlight just two of many tools that we use today, and of course we have to start with the polyclinic itself. There's no doubt that a polyclinic shapes people's moods and their overall perception of the entire healthcare system in the country. And this is why it has become our primary focus for transformation. Today, you can see the results, the new form these institutions have taken. This change happened on two fronts at once. On the one hand, there was the physical external modernization. On the other hand, and this is the key part, the entire inner workings, especially the digital processes, were completely overhauled. I must stress this again, all of this was done in constant collaboration with public feedback. Every major pillar of the system was discussed with medical workers. How it should look, how it should work, how digital tools were constantly being improved to make care better and the experience more user-friendly. At the same time, we always discuss what we can do to optimize these processes. It is clear that all the processes we are implementing today must be as effective as possible. Our primary objective is now to minimize the unnecessary contact with the patient. This means that if a patient needs documentation, for example, they should be able to obtain it in the shortest time possible, including remotely. The goal is for a person to require as few in-person visits as possible to receive care for their health concerns, to have a diagnosis established more quickly and consequently to begin treatment sooner. Ultimately, it's about enabling faster access to high-quality medical care. In achieving all of this, we are, of course, supported by the unified digital platform of Moscow's healthcare system. This is a comprehensive and robust framework. It integrates data on everything happening with the patient across the continuum of care in the polyclinic, the hospital, even in ambulance services. We have already implemented processes for remote monitoring of health indicators. Patients will have the ability to input their own data, allowing us to respond to it promptly. This is, without a doubt, one of the most advanced systems of its kind in the world today. Now, perhaps the most interesting and recent tool that we have, the one that has been needed for a long time and was implemented just this year, is the medical history summarization feature. In the past, with paper records, we, and especially frequent visitors to medical institutions, had to manually compile epicrizes. A patient's medical history would grow to hundreds and hundreds of pages. You'd create an epicrizes, and then a physician would rely on the summary for further decisions. But this new summarization feature essentially creates such an epicrizes for every specific patient, for each specific patient visit. So here's how it works. Before booking an appointment, the patient lists their complaints. When they arrive for the consultation, the first thing the physician sees is a consolidated overview of that current visit, current complaints, all corresponding medical documents for this specific issue, and all relevant data. The physician no longer needs to dig deep into the entire medical record to find this information. It's all presented clearly right in front of them. This already utilizes artificial intelligence technologies, suggesting that the three most probable diagnostic groups. This tool did not appear out of nowhere. It emerged naturally under the influence of many factors, including extensive discussions with numerous medical professionals. It was born from the very issue Elena Ivanovna mentioned previously. The reality of having figuratively only 11 seconds before an interaction with the doctor is disrupted. This tool is designed precisely to make communication with the patient as productive as possible. We no longer spend half the visit or even more time studying the medical record of the patient. We truly have all the information at our fingertips right from the start. As a result, the conversation with the patient becomes very productive and informative. And this is what allows us to enhance the effectiveness of the medical care we provide. The second interesting tool I'd like to present today is the suite of models used by healthcare administrators in their day-to-day management. I'm referring, of course, to the management dashboards. These dashboards are highly flexible, they are in continuous improvement, they adapt to various factors and feedback. You can literally track how their design and functionality have evolved over specific time periods. We constantly make adjustments based on input and feedback, and here once again we see the role of sociological feedback. Regular services are conducted among the heads of institutions and medical staff. The goal is to ensure that the data that we present is the most relevant and actionable. The power of the dashboard lies in its versatility. It can provide a high-level overview of the entire institution, a specific department, or performance in particular medical specialties. At the same time, it allows the manager to drill down to the most granular level, right into a specific patient's medical record. These are, of course, indispensable tools. They enable leadership. This means that deputy heads and directors of medical organizations to make data-driven decisions and launch targeted initiatives to improve the quality of medical care that we deliver to our patients. Naturally, without these very mechanisms of feedback, our platform simply could have not developed so rapidly and this efficiently. I want to reiterate, if you look at this journey since 2011, what has happened to the medical system within this 10 or 15 years, such progress would have been impossible. It would have been impossible without the constant work of focus groups, without the ongoing collaboration, including with our colleagues from the Research Institute for Healthcare Organization and Medical Management on various service and strategic sessions. It is precisely in these forums that these tools are either refined or conceived from the ground up. Thank you so much for your attention. A huge thank you for being such active participants in shaping this work. Thank you. Thank you, Andrei Alexandrovich. You mentioned 2011. Looking back over this past 15 years almost, how have the internal dynamics of the system evolved? Specifically, we are talking about the dialogue between the patient and the doctor with the influence of technology. What significant shifts have you observed? A doctor is also a human being. We must never forget that. But what I'm trying to say is, I was once asked how I would define myself. My immediate answer was, I'm a doctor. Only then did I add, I'm a human. And also, I'm a man. So indeed, being a physician came first, and your question is very insightful. The dynamics, the relationships between the doctor and patient among colleagues, even the connections between patients themselves, have undergone a colossal shift thanks to these integrated information systems. Think about it. Today, nearly every patient has instant access to their child's full medical history. Many of us monitor our elderly patients' parents' health records. We moved past the era of describing symptoms in layman's terms. Now we can simply say, please take a look at my latest test results in the app, sharing access instantly. This changes the entire format of care, delivery, and interaction at a fundamental level, and this transformation is still ongoing. But the feedback is fundamental. None of this would have been possible or effective without constant feedback. Every tool we develop, without exception, goes through rigorous testing before it reaches a wider audience. And here is the key difference from the past. If we look back, say, at the 1990s, a pilot project would often receive significant funding, be deemed positive, and then be rolled out broadly in its original form. Our philosophy today is fundamentally different, though. The journey from the initial design document and pilot project to the final implemented product often results in something radically improved, sometimes entirely reshaped by the piloting process itself. And this is an excellent development. The goal of a pilot project is no longer to just confirm that the idea is good. The goal is to use that pilot project as a live laboratory to perfect and refine these processes. Thank you. This leads us perfectly to our next topic, how to measure the human relationship within the healthcare system. The connections between all participants, the doctor as a human, the patient as a human, exactly what we've discussed, and measuring this human dynamics is precisely the domain of sociological research. As an international forum, we are now honored to welcome our next speaker from Canada, Professor Peter Nugas. He's Associate Professor and Deputy Director at the Institute of Health Sciences Education at McGill University, holding joint positions in the Department of Family Medicine and the Department of Oncology. He will share his expertise on qualitative sociological methods. These are the tools that allow us to assess and understand these human interactions and, crucially, to use those insights as a blueprint for building a healthcare system that remains human-centered.
Hello, everybody. My name is Peter Nugas. I'm delighted to participate in the Sociology of Health Forum, and I'd like to begin by thanking Professor Ignat Bogdan for the invitation and opportunity to present as part of this plenary panel. I am a sociologist and ethnographer, and I'm based at the Institute of Health Sciences Education at McGill University in Montreal, Canada. And the title of my presentation, as you can see, is Qualitative Sociology, Building Effective Human-Centered Healthcare Systems with AI Integration. So the objective of my presentation today is to highlight the practical value that qualitative sociology has in helping us create efficient, trust-building, and human-centered healthcare systems using an AI-related case study. There's a challenge that our health systems face today, and it's a tension between what we increasingly recognize as the transformative potential of artificial intelligence for increased efficiency, accuracy, and accessibility, but at the same time, promoting or maintaining qualities of human-centered healthcare systems, which we recognize as being characterized by empathy, shared decision-making, and interpersonal trust. So let's begin with a definition of artificial intelligence. I'm defining it as software that can sense, reason, learn, and act often better or faster than humans at specific tasks by processing massive amounts of data and recognizing or generating patterns. I'm deliberately avoiding the use of the term intelligence because that's quite a contested term. Some basic examples of AI in healthcare are diagnostics, administrative automation, and predictive analytics, such as diagnostics for early detection of cancers or fractures, administrative automation in the form of ambient scribes, which can reduce the burden of documentation on healthcare professionals and administrative staff, and predictive analytics for patient triage, which is the prioritization of patient need and urgency, and personalized treatment plans. There is a concept which is fairly well established in discussing the relationship between technology, but AI in particular, and human beings, and that is the idea of the human in the loop. And I think that's a very useful concept to start with. It's the principle in which human actors remain actively and meaningfully involved in the core processes of technology, including sensing, decision-making, and acting, rather than being fully replaced or relegated to mere supervision of an autonomous system. So let's look at a uniquely sociological view of AI. A uniquely sociological perspective of technology in general is that humans and technology are not separate from each other. They always have been, and they are inevitably entangled, to use a sociological term, and interdependent with each other. That means they influence each other, and they always have. A core principle is that, and which has also been demonstrated in empirical research, is that technology only works when it is so embedded in everyday routines that it actually becomes invisible. It's something that we don't consciously notice. A sociological term for this is to say that it is socio-material. So let's talk about achieving what we consider to be effective AI-human integration. An important point to concede is that just because humans and technology are inevitably entangled does not mean that it's necessarily a good entanglement. The moment that an AI intervention, like a new AI tool, enters a ward or a clinic, it reshapes the way healthcare professionals think, how they document their work and patient care, and the decisions that they make. But the reverse also happens. Clinicians immediately start reshaping the tool itself. For example, in overriding the tool sometimes, in workarounds to do something different from what the tool's suggesting, and providing feedback which the AI tool integrates. I think a useful dichotomy in talking about such entanglements are to consider them as either careless or careful. Careless entanglements include what we might consider to be opaque outputs. They're outputs, they're suggestions made by an AI tool that a healthcare professional says, that doesn't make sense to me. It's implausible. I don't really believe it. It can also erode skills and generate a lack of confidence in the decision-making ability of healthcare professionals. It can amplify bias, which has been demonstrated in the US and Canada, for example, in biasing people who are not white, for example, people of color, and it can contribute to burnout through constant alerts, and also healthcare professionals and administrative staff having to regularly make corrections for bad advice, from AI tools. Careful entanglements include entanglements that are transparent, explainable, clinician-controlled, and continuously adapted as needed by healthcare professionals, administrative staff, and patients. So, achieving effective AI-human integration involves keeping humans in charge. So we consider it like flying a plane. It's not about putting something on autopilot. It's about co-piloting. And it's not about keeping technology at arm's length either. It's about designing the entanglement so that human judgment, empathy, and accountability qualities that we see as central to human-centered healthcare systems remain central in this hybrid practice that emerges. So let's talk about qualitative sociology. We're talking about fixing systems that fail people. It's really important to note that healthcare systems and medical systems are not just about science or machines or clinical indicators. That's often what we consider when we think of medicine and healthcare. Unfortunately, it's what we think about in medical and health professional education. And we underestimate the degree to which human beings are involved and make decisions. And so I'm going to use one example of healthcare errors or mistakes or adverse events. Not to show necessarily the error proneness of healthcare, but because I think this really demonstrates strongly how central human beings are in making healthcare work, despite the fact that we have science, machines, and clinical indicators that modern medicine and healthcare rely upon. So for example, we found in research that problems of communication and coordination are implicated massively in healthcare mistakes, adverse events. 25 to 30% of clinical errors generally come from communication or coordination challenges. 60 to 70% in the case of serious or sentinel events, and up to 80% of mistakes or errors during patient handoffs or handovers from one healthcare professional to another. So it's very important now in talking about qualitative as opposed to quantitative sociology, both of which work in harmony together, but qualitative sociology makes a unique contribution. While quantitative research tells us whether something works or not as an outcome, qualitative research tells us how or why something works or not. Qualitative research, as we know, I'm sure, deals with words or images rather than numbers. Although numbers are sometimes included in qualitative analysis, and the two types of research are complementary. Qualitative research typically includes interviews, one-on-one with people, larger focus groups, observations of real-life live situations, document analysis, such as seeing whether the policies of an organization match what happens in practice, or image analysis, or any combination of these methods. The important thing is that if we want to improve the way something works, or we want to transfer lessons from one setting to another, such as in the case study I'm about to present, we need to know about the perceptions that people have and the processes of their use. In other words, how or why something worked or not. So let's use a case study. We're looking at sepsis and this AI tool called Sepsis Watch in the emergency department, which is an innovation that was introduced in the emergency department at Duke University Hospital in the United States. So sepsis is an extreme, life-threatening response to an infection that gets out of control. It can cause widespread inflammation, organ failure, and tissue damage. It kills about 11 million people worldwide every year, so it's very serious. It's important to consider this in the emergency department because many people with sepsis come to the emergency department already very, very ill or deteriorating rapidly. And every hour of delay in treatment can increase mortality by between 7 and 8%. So Sepsis Watch is this AI tool that was introduced. It watches patient records every few minutes to look out for signs of sepsis many hours earlier than is normally able to be observed. So that's its innovation. What it does is it quietly indicates patients who are high risk to a special response nurse, and it does so in simple, plain English, giving the reasons why they're at risk so that the team can start life-saving treatment faster than they would have. And it also tries to keep doctors and nurses fully in charge. Now, there have been some problems in the implementation of this new system. it was found that some of the AI alerts were often ignored, sometimes not acted upon. Doctors and nurses were frustrated by what they perceived as limited quality of the innovation, and the improvements clinically were not happening at the rate that was expected. So they intervened with a qualitative study. They did 15 semi-structured interviews with doctors and nurses. So this is a summary. I'll go through it very quickly. These slides will be available, so I don't have time to do it in great detail, but just so that you know, this is 6 particular challenges or problems that the qualitative research identified. It's about alerts being poorly timed or disruptive of very, very busy clinical work, clinicians not understanding what the problem was, nurses feeling that their professional judgment was ignored by the system, a fear of being over-alerted, having too many alerts interfering with work, a lack of trust in the recommendations, and physicians wanting to know when the model had been overridden or when it was ignored. So on the right-hand column of my slide, you can see the responses that were actually intervened, such as having the logic presented to staff and having the logic, the timing added in a quiet period in particular after the initial arrival, so that alerts could only be escalated once meaningful data was accumulating, not getting constant alerts. Adding plain language to explain high-risk alerts, to redesigning the workflow so that the alerts only happened to the relevant nurse, and the nurse was reviewing and deciding when to page the doctor. Introducing a new risk threshold slider so that each unit could tune and suppress repeated alerts happening in a very timely and relevant fashion, and creating short training videos which were based on the complaints that staff had in the qualitative research, and adding an audit trail so that you could see every alert that happened and what the action was that was taken, so that you could constantly improve the system. So not only were these innovations introduced and these positive changes to the system, but the clinician satisfaction actually rose from 30% to 80%, of how they use. So there's a lot of health professional satisfaction. Also, Sepsis Watch expanded from the emergency department to the whole hospital and became standard. And there are a number of clinical improvements, such as shorter hospital stays and improved and faster distribution of antibiotics and fluids. So let's just look at what this means to come back to something in terms of the principles that we're looking for. What are human-centered AI principles? And this can help us evaluate whether a new innovation of AI or technology is actually human-centered. I won't go through the details, but I'll just summarize them very briefly. We've got transparency, plain language explainability, usability that matches everyday work, appropriate training, and human oversight or augmentation that keeps humans in control, making the decisions, but also being accountable for those decisions. So in conclusion, we can see that by appreciating the interdependence of people and technology, qualitative sociology provides practical tools to uncover why systems work or fail, enabling specific and targeted and practical improvements. Qualitative sociology bridges the gap between technology and people. It ensures that AI enhances healthcare, as we've seen, and by listening to people's experiences and perceptions, it builds the trust needed, and we can build the trust needed for technology to transform healthcare. So finally, qualitative sociology does not just describe problems, which is what it does very well, but beyond that, it shows us how to fix problems, making healthcare both efficient and humane.
Thank you, Peter. This is highly important. Today we are discussing which tools are most effective for assessing a person's trust and for informing the everyday practical decisions within our healthcare systems. Whether we use qualitative or quantitative sociological methods, we must always consider how our findings will ultimately lead to change within the healthcare system. But these necessary changes are not solely about trust or empathy. They're also deeply connected to other human values, such as individual culture or the social norms prevalent in a given country. Our next speaker presents South Africa and brings a profound professional perspective to this issue. He examines the critical question of humanization in the era of digital healthcare, exploring how spiritual beliefs and communal practices shape an individual's perception of their own health and the healthcare system at large. This, too, is a vital focus of sociological inquiry. It is my pleasure to introduce Alex Asakitipki, Senior National Researcher at the Faculty of Humanities and Social Sciences of the Independent Institute of Education and Ambassador for the UNESCO UNITWIN project. He will discuss how sociological research can measure and understand the influence of diverse spiritual and communal ethics on people's attitudes towards health and healthcare systems. Alex, welcome.
So, distinguished colleagues, ladies and gentlemen, it is a great honor to join you at the Moscow 2025 Sociology of Health Forum with its theme, Safeguarding the Human Core of Healthcare in Times of Rapid Digital Transformation. I am grateful for the opportunity to share reflections from an African sociological and ethical lens on what I consider one of the defining challenges of our time, that is, how to preserve the human core of healthcare as it becomes increasingly digitalized. Before I continue, permit me to express my gratitude to Professor Ignat Bogdan for inviting me to make this presentation, as well as to Maria Vyacheslav for her kind and professional assistance in putting this presentation together. I send warm greetings to you all from the beautiful city of Johannesburg in South Africa and from the continent of Africa more broadly. I have titled my presentation, Humanizing Digital Healthcare, Embracing African Spirituality and Communal Ethics. As a preamble, let me begin with the African proverb that says a person is a person through other persons. In Zulu language, it says umuntu ubuntu agabantu. Amongst the Uwe of Nigeria, it is couched in that language as Mira Ifoki Ura. So this conceptualization of the individual as interconnected with the community and the universe is important in understanding how health in its dramatic forms and the digitalization of it in this period that we are in can help us to have a better understanding of health, healthcare, and healing in Africa. So this whole concept of a person is a person through other persons is known in Southern Africa as Ubuntu. Ubuntu is a philosophy that reminds us that personhood is not an isolated possession, but a shared experience of mutual recognition, so that the individual does not live in isolation, does not operate in isolation, but is interconnected with his family members or her family members, as well as the community, the environment, and the supernatural. With the advances in technology, and specifically in medical sociology, medical technology, As machines learn to diagnose, predict, and decide on issues relating to illnesses and diseases, what we must therefore ask is, how can we begin to train machines to learn to care? That is important within the context of the philosophy of Ubuntu. The digital disruption of care, starting from I will place it in the year 2020, which marked a historical watershed in the history of humanity, ushered in by the COVID-19 pandemic, as well as with the official launch of ChatGPT to the world in November 2022, we see the rapid digitalization of healthcare as it transforms the ways in which we understand illness, healing, and human connection. And it will evolve more rapidly in the next 10 years. And so we need to position ourselves to have a good understanding how this can best serve our purpose, not only in Africa, but also globally. Presently, we see artificial intelligence interpreting medical images, telemedicine bringing doctors into our homes, and precision medicine mapping our genetic identities. What therefore becomes so important to us is what happens when the screen replaces the bedside. What happens when patient narratives are reduced to data points? And what happens when cultural and spiritual meanings of illnesses are flattened by algorithms in their natural forms, which is dispassionate and neutral? These developments offer remarkable promises where, from an African perspective, we should not only digitize medicine, we should simultaneously redefine what it means to heal. The challenges we face, therefore, are not necessarily rejecting digital transformation, but how best we can humanize the machines that are being developed today to aid healthcare. So it is within this context that I present Ubuntu as a relational personhood and as a way of understanding the aspects that is so important in the healing process. In many African societies, the idea of health is inseparable from relationships with family members, relationship with the community, relationship with the environment, relationship with ancestors. The supernatural is so very important because it frames how Africans define diseases and illnesses and how it influences their health-seeking behavior. Ubuntu expresses this worldview in the simple truism, I am because we are. Health, therefore, is not merely the absence of diseases, as the World Health Organization has also noted in its definition of health in 1948. But what the WHO's definition did not take into consideration is the spiritual dimension of health, the religious and spiritual dimension of health and healing. So from the African perspective, health is not just the absence of disease, it is the presence of balance, the balance between the individual and their social relationships, the moral dimension, as well as the spiritual dimension. Illness, therefore, is seen not only as a biological breakdown, but as a disruption in relational harmony. And that is where I want us to look at the place of AI in dealing with healing from the African perspective. So in attempts to frame health from an Ubuntu perspective, we discuss Ubuntu as providing a different ethical foundation for digital health. It asks not what can technology do, but how technology should relate to patients, to significant members of the patient, as well as the community at large. Ubuntu also calls us to design AI systems that are not merely intelligent, but empathetic, not simply efficient, but relational. We think that within this framework is evolving health landscape and how South Africans respond to the issue of AI and medicine. Telemedicine and rural trust somehow is very difficult to capture, because during the COVID-19 pandemic, rural communities were encouraged to consult doctors via phones and videos. Many patients, however, hesitated because they found the interaction distant and emotionally sterile. When community health workers, however, began framing these consultations in spiritual and communal terms, saying things like, we are keeping the spirit of the family strong by protecting one another, acceptance rates rose dramatically. So one lesson that can be learned, therefore, is that digital health gains traction when it communicates in the moral and spiritual language of the society, of the community, so that it is not detached, but it is engaging and therefore part of the worldview of the individuals. Secondly, AI health applications and cultural literacies. Several mobile health applications are designed by international developers, but these have initially failed because the problem was not technology, but the tone that was used. The apps addressed users in impersonal English language, ignoring indigenous languages and idioms. And as noted by Talder and Bottomley, 2025, when they conducted the response of South African public as a way of trusting AI, they found that significant majority of the population, over 73% of the population, expressed preference for a human doctor rather than an AI doctor. So if it is redesigned to include local greetings, moral respect, and contextually resonant metaphors, we can easily predict that usage rate would sharply increase. So the lesson we can learn from these studies is that digital empathy begins with cultural literacy. We have to know how care is expressed and received in various contexts. And in the African context, there's the dimension of the community, there's also the spiritual dimension. And the third reflection is the integrative healing centers that various studies have found that the various ways in which people interact in healthcare centers also speak to how they interact in traditional centers. So in Johannesburg and Durban, for example, some clinics are now experimenting with collaborating between biomedical doctors and traditional healers. Such shared digital records allow patients to benefit from both worlds, the worlds of antibiotics alongside herbal remedies. counseling alongside prayers or propitiating the ancestors. So what can be learned from this is that interoperability should not only mean technological compatibility, but also moral and cultural interoperability. Such systems are very important because they help to acknowledge the multiple pathways to wellness. So we are trying to see how we can incorporate Western form of healing and traditional forms of healing. If there are ways we can think of incorporating them, then it will be a game changer for the majority of African peoples. Now, looking at the theoretical synthesis of Ubuntu-centered digital ethics, the experiences that we've had as far as Africans responding to the evolving nature of healthcare is concerned is what I call the Ubuntu-centered digital ethics, a framework that attempts to reclaim the moral core of healthcare in a digital age. And it is within this framework that we have three interrelated pillars: the relational design, the cultural co-creation, and the moral accountability. And together, these principles reimagine AI not as an autonomous intelligence, but as a relational intelligence that can understand healing as a shared moral enterprise. But what are the implications for the broader global health challenges that we are confronted with? One is that it challenges the common assumption that innovation must not necessarily flow from the global north. Secondly, it's a reminder that technology is never culturally neutral. The design of algorithms, user interfaces, and communication protocols reflects hidden moral choices. And it calls for a new kind of partnership that combines digital expertise with sociocultural wisdom, ensuring that the global march toward digital medicine does not trample the local meanings of care. So in this regard, we say that we must begin to think of how to globalize compassion within the framework of the Ubuntu philosophy. And in conclusion, we will say that if the 21st century made healthcare more scientific, the 21st century must be about making it more human, even in its digital form. Secondly, Ubuntu teaches us that the essence of healing lies not in the transaction, but in the relationship amongst people and the environment and the supernatural. Thirdly, if guided by ethical imagination, technology can amplify connection by extending empathy across distances, cultures, and codes. In continuing healthcare digitalization, let us not amputate empathy in the process, but let us see how we can humanize the process for the benefit of humankind. Thank you very much. Asante sana, a Swahili word which means you are appreciated. Thank you.
Thank you, Alex. A truly fascinating approach, one that resonates deeply with our own focus on developing and strengthening public health in the Russian Federation. Of course, the philosophical aspects of shaping the value of health, not just for the individual, but for an entire population, is an extremely important direction today. Dear colleagues, we have navigated through a significant part of our plenary agenda. And it is crucial now to discuss not only the role of technology in generating new sociological knowledge, but also the reverse, how sociological tools allow us to see our own work in a completely new light. If until recently sociological tools primarily measure what is happening here and now in the relationships between patients and physicians, between the individual and the healthcare system, the emergence of new sociological methodologies now allows us to go even further. They enable us to forecast and even guide human behavior within the healthcare landscape. They create new channels for engagement and help build new forms of dialogue. Next, I would like to invite our next speaker, Kirill Sergeyevich Rodin, Director for Relations with Government Bodies at VII, which is the Russian Public Opinion Research Center. For many years now, Kirill Sergeyevich has been deeply engaged in studying trust within the healthcare system and various technologies in the state itself through the lens of sociological tools and the prism of healthcare. Please, I give you the floor.
Good afternoon, colleagues. Thank you very much for the invitation.
It's true, this is not our first meeting, and it's always a valuable opportunity to both share our findings and to engage with such interesting people. Let me start by highlighting a couple of key points, and then I'll walk you through some of our data. Of course, given the time constraints, we won't be able to cover everything, but I hope to show you a few illustrative examples. First, we are living today not simply in a period of innovation, but in a period of accelerated innovation. If we look back, let's say, at the average Russian from 200 or even 100 years ago, let's say it was entirely possible for a person to go through their entire life without encountering a single major innovation. They might have heard about something like, I don't know, like light bulb or television introduced to some distant city. But today, however, the pressure of innovation on the average individual, in our case, the patient, is immense. Because healthcare, from a technological standpoint, truly stands at the forefront of societal progress. As a result, people find themselves caught in a veritable whirlwind of constant change. And what we consistently observe and document is, and what we always try to emphasize in our recommendations, is that people do not always find it very easy to adapt, and certainly not quickly, to the innovations happening around them. And today, the pace of change is so rapid that by the time people adapt to one set of changes, those changes have already evolved into something new. In this environment, individuals shaped by public opinion often find themselves unprepared and confused. And we all know how that plays out. If we don't know or understand something, imagination runs wild. Word of mouth, self-proclaimed online experts, they all step in. Reliable information about technological innovations gets replaced by rumors and myths. Why are rumors and myths dangerous? Well, it's obvious. First, they become a dead weight, dragging down any innovation because people start to fear it. Take artificial intelligence, for example. We have conducted research on AI and its introduction into various spheres of public life. So, when we asked people whether they were ready, whether they thought it was necessary to apply AI in different areas, as for readiness to implement these technologies in industrial settings, people responded with interest and understanding. They felt it should be actively adopted. However, when it comes to healthcare, and we understand that this is tied to their own health and the lives of their children and relatives, people grow wary. Essentially, healthcare ends up in last place for innovation. People are extremely cautious. They want to measure twice and cut once, which is quite an apt metaphor for our discussion today. However, this also highlights another critical issue we must pay great attention to. The very same technologies like artificial intelligence and other high-tech innovations are tools that can be used not only by dedicated professionals, but also by malicious actors and fraudsters. I'll be honest, I'm not an IT expert, but we see it all around us. The rise of fake websites, robocalls, and scam people by exploiting their trust. Naturally, the highly sensitive sphere of personal health and medicine and data becomes one of the primary targets for these attacks. Now, for a second point, and this perhaps a perfect topic for a forum like ours to really dig into and debate. It is about the very role, the function and role of the physician in the future within this new kind of healthcare being created today. We see a fascinating trend here. On one hand, data shows that the prestige of the medical professional society is growing and growing noticeably. This trend has been building, but one of its key catalysts was undoubtedly the whole COVID-19 situation. Despite the many difficult and conflict-ridden situations and the understandably high levels of social stress, the public gained a deep appreciation, nevertheless, for the immense burden and the critical role that doctors carried, that they performed throughout the pandemic. They were seen as soldiers on the invisible front line. The society recognized the weight they were bearing. And here, the second part of that question is, against the backdrop of rapid technological advancement, how exactly will the physician's role transform? If we look back at the origins of the profession, perhaps to the Middle Ages, the role was essentially sacred. The doctor was a person who could perform mysterious and comprehensible manipulations to save a life or alleviate pain. But today we're entering an era where artificial intelligence aids in thinking and robots assist in surgery. While these elements are somewhat fragmented, if we take a futuristic leap, whether it's 10 or 20 or 30 years, it's likely that these technologies will become pervasive. Health monitoring is also shifting into the realm of high technology, and so on. This begs the central question, where does this leave the doctor? What will their core function be? Will they simply become navigators through high-tech systems, directing patients to the right room, essentially performing an administrative role, or will they evolve into consultants of sorts? Or perhaps their role will transform into something else entirely? This is precisely why I say this is a question for the experts. It's a bit more challenging for me to speculate in depth. This touches the very heart of the profession, and a truly professional perspective is essential here. But as promised, let's go through key data points quickly. The results I'll share come from our daily telephone service, where we interview 1,600 Russians aged 18 and older. The sample represents the opinion of the entire adult population of the Russian Federation. First point is doctors, the heroes of our time. This relates directly to what I mentioned earlier. Over the last 2 years, we've seen a consistent and a growing trend. Every year, we conduct a ranking of professions, asking people, who would you call a hero of our time? If we look back about a decade ago, the medical profession wasn't at the top of terms, wasn't at the top in terms of prestige. The leading positions were held by officials, businessmen, lawyers, and economists were also prominent. But doctors, along with teachers, were somewhat around the middle or even lower in that ranking. Today, the situation has changed radically. There is a clear shift in perception. For many of our compatriots, the future, promising and prospective future, is now seen in the medical profession. Doctors have moved to the forefront. We also used a straightforward marker question that went like, should we increase the salaries of medical professionals? And here, as one might expect, given their perceived role and function, the response was overwhelmingly positive. People broadly support this idea. The doctor is seen as a prestigious profession. We asked, which professions do you currently consider to be the most prestigious for yourself? And looking at this chart, right now, we can see that the top two spots are essentially tied, each held by a third of respondents. It is divided by specialists in computer technology and healthcare professionals. All other professions stand noticeably apart. But what's important to highlight, and this relates to what I mentioned earlier, is that starting from 2012, we see a remarkable shift in the prestige of the medical profession. It has been growing significantly. Furthermore, we ask more sensitive, telling questions such as, would you like your children to work in this field? What professions do you wish for them? This is a very revealing question because we always want the best for our children. And here, too, the standing of the medical profession is rising noticeably. People are increasingly seeing it as a desirable and promising path for their next generation. Now about technologies. I'll give you an example from telemedicine, as I touched briefly on artificial intelligence here. First of all, we asked whether you personally had heard or are hearing for the first time now about the possibility of getting a doctor's consultation by the phone. We conducted such a survey this spring, and 59% of the respondents told us that they were aware to one degree and another. In 2020, by the way, the figure was practically the same within the margin of error. It was 62%. Does this indicate that the field of telemedicine has to a certain degree exhausted its potential in terms of the audience segments increased in this form of interaction with the healthcare specialist? Well, it's hard to say. Most likely, of course, these teleformats, let's call them that in general terms, services related to communication by phone and the internet, they will probably continue to develop. We also asked about the demand for the service. Here we didn't just ask about awareness, but asked, have you personally had a remote consultation like this with a doctor by phone or via the internet? Now, if you look at the numbers, in 2020, this figure was 2.6% for us. In 2025, when we asked this question, the total share of the audience who had used it had already increased to almost 25%. So, indeed, over this, let's see, 5 years, we have made significant progress. And I think it's unlikely that we will stop here. Of course, this direction will also continue to develop. So, colleagues, I will not be listing all the conclusions. In many ways, they echo what we've just been discussing. The only thing I'd like to emphasize once again is, firstly, the very interesting questions of how the doctor's role will change. And secondly, how we need to prepare the public opinion for the introduction of these very innovations. We do have specific sectors where we are beginning to implement these advanced intelligence systems. And yes, there are major gaps in there as well. But within healthcare itself, it is critically important that in those areas of high-tech care that are rapidly evolving, we step up the efforts to inform the public. People need to understand what these technologies are, how they work, where they're being used, and what their current limitations are. We have to prevent fear and stop myths from forming the kind of that emerge when people fill in the blanks when we leave them unfilled. Thank you.
Yes, thank you. Starting this year, we have actively begun collaborating with our colleagues from Belarus. That is why we have invited our next speaker, Alexander Mikhailovich Belsky, head of the Operational Research Center at the Institute of Sociology of the National Academy of Sciences of Belarus. He's here with us. Our main collaboration now is focused on understanding which joint sociological tools for comparative research we use. This is a very interesting direction here, because at a certain point of time, Belarus and Russia interacted quite closely. Then our paths diverged, and now we're starting to collaborate again. We see now how many common interests we have, how we are following similar paths here, and which sociological tools can help us change the overall landscape and make the healthcare system, the global healthcare system between our countries, more unified. So please, Alexander Mikhailovich, we are giving you the floor. Good afternoon, dear colleagues. Thank you very much for the invitation to speak at such an important and significant forum, a forum dedicated to healthcare, a key systemic sphere on which our health depends. And without health, of course, there can be no realization in all other spheres. My name is Alexander Berdyklychev. I'm the head of the Operational Research Center at the Institute of Sociology at the National Academy of Sciences of Belarus. And as is already clear from the name of the institution I represent, our structure is not specialized in the study of healthcare. However, given the importance of this field, which I have just outlined, and as the leading national research institution in the field of sociology, we certainly cannot leave the sphere aside or bypass it in any other way. It does fall within our scope of interests. For example, speaking about the center that I had, for 5 years now we have been conducting research using telephone service concerning the development of our domestic healthcare system, satisfaction in this area, touching upon aspects of vaccination, vaccine manufacturers, in general, aspects related to the willingness or unwillingnness to get vaccinated and the factors that influence these processes. Furthermore, our research, of course, includes both a monitoring component that allows us to track the dynamics of key indicators and blocks of questions that are so pressing and extremely relevant in the current situation. Speaking specifically about the digitalization of the healthcare sector, we asked our respondents, who are residents of our country, Belarus, because it was a national survey, whether they were ready to use online consultations with doctors to contact and communicate with them, presumably through messengers or other formats or platforms. So currently about 40% of the respondents we surveyed declare such readiness, if we are to cite some specific figures here. However, such a form of booking a doctor's appointment as booking through healthcare institutions' internet portal website is not very popular among the participants of our study. About 1 in 5 people, roughly 20% of the respondents, book doctor's appointments through websites. The rest overwhelmingly prefer booking by phone, which remains the most familiar option. The in-person format is also highly popular as it provides the possibility of getting an appointment ticket on the day of the request and accordingly receiving highly qualified medical assistance on the spot immediately. If we talk specifically about internet bookings, the factor at play here is likely less about the bias against this method and more about the aspect related to the actual availability of appointment slots. That is, typically our internet available slots have a longer waiting period. It can stretch up to a week. In addition, the healthcare sector is included in our studies and is examined through in-person household surveys. We're talking about classic questionnaire-based type of household service. If we talk about the recent data collected by this information gathering method, here we have been tracking, among recent findings, whether our population, as part of such health-preserving strategies and self-care practices, whether they use any electronic gadgets. Gadgets that allow them to record key vital indicators, track their dynamics, and subsequently take some action to bring those indicators back to normal if they deviate from reference values. They do that either by consulting a doctor or by taking independent steps based on individual choice. So, unfortunately, approximately 60% of those surveyed do not keep systematic records. They do not list their key vital indicators. This can be done in various ways. One can keep handwritten blood pressure diaries. They can use, indeed, gadgets worn on the wrist like watches, where everything is recorded in an application automatically. While 60% do not do this in any format. 17.6% of the respondents use gadgets that can be categorized as smartwatches with extended functionality, and only 3.5% of respondents use those applications that they can actually download and accordingly use in a monitoring mode to track specific indicators. When we look at the research by young scholars, healthcare is certainly represented there too. It is represented by interesting dissertation work, I'd like to point out. One of these studies focuses on the population's self-preservation strategies. Specifically, this dissertation puts a strong emphasis on the system of preventive medical checkups as an ongoing, important, and highly relevant process. A great deal of attention is paid to these checkups. However, how this checkup process is reflected in actual self-preservation and health-maintaining practices remains a relatively understudied phenomenon. This is because the checkup system itself, as a centralized program, was only introduced and integrated into mandatory procedures quite recently. When it comes to large-scale specialized projects, we're fortunate to see that the Belarus Ministry of Health is genuinely interested in having its initiatives backed by academic research. And often the ministry itself acts as the initiator of many such interesting, diverse projects. The sociological component here is also represented among those projects, and we are pleased to be the ones providing it. Our Operational Research Center, in collaboration with the Belarus Republic Scientific and Practical Center of Medical Technologies, which is the key specialized institution providing scientific support for the Ministry of Health, has managed to implement several large-scale national studies over the past 4 years. These studies were very diverse, and I think I will focus on the key ones. So, those are fundamentally different from each other, and I believe that they will allow us to delve deeper into the range of issues that we are studying. Our first major project was about developing a tool to measure patient satisfaction. We focused on satisfaction across different settings: polyclinics, hospitals, and day patient departments. Essentially, the entire spectrum of care that a person can receive. Because ultimately, both the quality of care and how satisfied patients feel about it are the most important indicators of how well our medical institutions are performing. So, what was the main goal? We needed an instrument that could be used locally, on site, to get a real sense of the situation in each specific area. This would allow regional health authorities to collect their own data and compile it, and on a national level, it will give the ministry a clear view. The ability to monitor satisfaction trends across the country, to understand the current state of affairs, and most importantly, to identify the key areas that need improvement and attention. To create this tool, my colleagues and I developed a set of 3 questionnaires for patients to complete on their own. We designed them to capture as much as possible, to really understand every factor that influences both the actual quality of the service and the patient's satisfaction with it. That meant including the questions about the treatment plan itself and the level of personal trust a patient has in their doctor. It meant asking about wait times for various tests and procedures. We also looked at the physical environment in hospitals and clinics, everything from general comfort down to practical issues like parking availability.
And of course, we factored in elements of accessibility and other important considerations for patients. Therefore, the questionnaire was designed to evaluate section by section every aspect of the service delivery process. It has also included open-ended fields allowing patients to voice specific opinions to highlight urgent issues that require immediate targeted actions from the administration of these medical facilities. We also prepared the questionnaires themselves, and we also developed comprehensive methodological guidelines. These guidelines explained how to conduct the survey, whom to survey, and the correct procedures to follow. We designed all the necessary forms in Microsoft Excel. We maximized the automation of the data entry process. We implemented features like input prompts showing that what could and couldn't be entered. We also introduced validation to prevent the entry of incorrect values. The system was set up to highlight problematic questionnaires, for example, those with too many difficult to answer responses, making them less informative, or those with a high number of skipped questions. So the goal was to make the entire process fully automated on the ground. This means that the person assigned to input the data, who might have not been the most tech-savvy, could handle the task without any issues. Furthermore, there had been significant criticism of past surveys conducted by the Ministry of Health. The criticism was that questionnaires would be filled out, sent somewhere, and then it became unclear what the results were, how they were compiled, or how they were taken into account. This leads to futile work, effort without feedback, which is, by definition, frankly ineffective. In our case, the second page of the developed form questionnaire immediately calculated the results. It immediately drew attention to where the problem areas were and so on. Consequently, the hospitals or polyclinics saw the picture right then and there, and they had the opportunity to make decisions to improve the situation. This, however, introduced certain complications into the study, because when the data was sent to the next level, many would correct the contraindications that had been identified, which is good for patients, but at the same time, human intervention also crept into moments related to, unfortunately, adjusting the raw data that had been collected locally. We had planned to survey approximately 45,000 users of medical services. After cleaning up the database, we were left with 35,000 valid entries. But again, those are issues connected precisely to these moments of potential data manipulation. Because of this, while developing future plans, we concluded that it would be better to organize such research using professional interviews. They would survey a smaller number of patients and service users, of course, right as they exited healthcare facilities. This way, we could control every questionnaire, verify all collected data, and thus ensure true representativeness of the study, rather than leaving it entirely to the discretion of individual healthcare institutions. Another interesting project focused directly on healthcare workers. If the previous one was about patients, this one concerned doctors and nursing staff. It addressed the pressing issues, which is staff turnover. The study used classic on-site workplace interviews, and here our own centralized and well-structured system worked to our advantage. We were able to formally notify the healthcare institutions about the visit of our specialists. Our arrival was scheduled and regulated, and at the same time created conditions that allowed medical staff to speak honestly and openly on the full range of questions that we included in our survey. And this range was comprehensive. It covered not only the obvious
obvious reasons for staff migration from one sector to another. The first thing that comes to mind is salary. But we went beyond salary to include the workplace morale, career advancement opportunities, availability of necessary reagents and supplies for diagnostic procedures, among other factors. Interestingly, one aspect that stood out particularly was the issue of mentorship. The system that prefers young professionals to integrate into productive medical service delivery. And these very aspects of mentorship play a crucial role in retaining medical staff and ensuring that they continue to provide effective care. This was very interesting and gratifying. It was gratifying to see that the Ministry of Health takes these findings into account and discusses them in its collegial meetings and subsequently applies this knowledge in practice. The results of these studies were also presented during on-site seminars, for example, to our colleagues from Kazakhstan. They were also very interested in conducting similar research in their own country. This is because, in principle, the challenges we all face are similar. This suggests that such a comprehensive research instrument could have relevance beyond our own borders. There is potential for cross-country comparison, at least within the post-Soviet space for starters. And now we are moving towards a completely new target audience, which is teenagers. Unfortunately, we do not have a detailed regulated system for surveying this population group. We have legislation concerning interrogations, which includes certain rules for the age groups that include teenagers. Naturally, fully applying these rules to sociological service is neither possible nor advisable. Our approach was based on the principle that from the age of 14, a teenager can make certain decisions independently. Therefore, we will analyze the 14 to 17 age group and account for risk factors that could potentially affect their health. This includes alcohol consumption, tobacco smoking, levels of physical activity, and dietary habits. Combined with data from their regular medical checkups, we will obtain a much more comprehensive picture. For this project, we were able to fully implement a data collection method based on online solutions. We developed questionnaires in digital forms with an extensive filter system, which allows us to ask only those questions that are relevant to specific respondents. For instance, if the respondent smokes, we clarify what exactly, whether it's heated tobacco sticks or cigarettes or vapes. If they select any of these, then we ask for details like the number of pods, sticks, or cigarette packs used, and so on. So we consider the survey down to such nuances. Naturally, this is quite convenient for a teenager coming in for doctor's appointments. They simply need to scan a QR code with their mobile phone, answer the questionnaire while waiting for their turn, and they are not directly under the doctor's supervision while during the consultation. This approach helps minimize the feeling of being monitored, which a teenager might experience in that situation. We also conduct research on aspects related to the stigmatization of patients. We have examined the stigmatization of tuberculosis patients, both the primary stigma they face and the secondary stigma experienced by their relatives, and even the doctors treating them. This too was a large-scale and fascinating project. Our regular trusted interviewers refused to collaborate with us on this due to certain preconceptions. But we didn't stop there. We found a way to reach volunteers who work with the specific patient groups. So these volunteers were able to speak with the patient themselves, their doctors, their relatives, and as a result, we obtained very comprehensive and objective data. Even though we conducted thorough specialized training with the volunteers and provided them with the constant consultation and support, the high motivation was crucial. It significantly influenced our ability to achieve the set goal despite initial reservations. We had considered using online methods maybe, but certain categories of tuberculosis patients, for instance, those, for example, without phones, undergoing compulsory treatment, or just unwilling to engage with as many people, require a different approach. So volunteers were able to find a way to connect with them. This highlights the importance of being willing to try and apply various solutions, including digital ones, in order to achieve our research objectives. We have established close contact with your institution's Center for Digital Sociology to make sure that digital solutions are used to build communication and foster collaboration. Right now, we are focusing on a joint publication focusing on the pensioner populations of our two capitals, Minsk and Moscow. And at this very moment, we are conducting a telephone survey targeting this specific age group. We have added a dedicated component that examines their quality of life in detail. And our plan is to carry out a comparative study to assess how data collected on this set of questions differs between residents of Minsk and residents of Moscow. We will use a single research instrument and a uniform set of questions, allowing us to compare the results for each category point by point. And digital technologies are precisely what allow us to communicate quickly and effectively, to collaborate even across a great distance, and for me to participate in this event today too. So thank you for the invitation. I will follow the rest of your forum with great interest online, and I hope that next year we will be able to meet in person. Once again, thank you. I wish you all a successful conference. Thank you, Alexander Mikhailovich, for your fascinating presentation. You have expertly showcased both your own projects and our collaborative work. I would only like to add that alongside these classic well-established types of sociological research for healthcare systems, assessing satisfaction, trust, and loyalty among various stakeholders, we also launched projects several years ago focused on developing digital sociology. For this, we utilize big data, neural networks, and a range of other tools such as social media analysis. Initially, these were, of course, fragmented, small-scale studies that allowed us to look at standard familiar processes from a completely new angle. However, this gradually evolved into a full-fledged field of work. And in fact, last year we even changed the name of our center to the Center for Digital Sociology and Socio-Humanistic Technologies in Healthcare. We are now actively developing this very direction. We believe that digital sociology is the future. The sheer volume of new technologies emerging in healthcare and at such great speed makes it increasingly difficult to measure everything through telephone service or questionnaires alone. Therefore, sociological tools must adapt to new technologies. And we already have a significant number of digital sociology projects underway at our institute. With this being said, I will now give the floor to the head of the center, Ignat Bogdan, so he can present his experience in this area in great detail.
Thank you very much, Elena Ivanovna. Good afternoon, dear colleagues, both those present here in person and those joining us today online. Today I would like to offer a broad overview of precisely what sociology in both digital and more classical sense can contribute to solving pressing healthcare issues. Speaking of the forum's theme, we are talking today about the balance between technology and humanity, about searching for a specific formula of trust. First, I would like to briefly outline
outline a few trends once more. My colleagues have already touched upon them most of them today, but I would like to highlight them specifically. I believe that these are precisely the areas where both digital and classical sociology can be most useful. The first area is, of course, digitalization. We've spoken about this, the general introduction of new digital technologies into healthcare, primarily AI technologies, and only within the past years we've seen generative AI really take off. So essentially we are witnessing truly profound digital transformations, and they're happening at an incredible pace almost every couple of years, one could say. Not a long time ago there was the pandemic with a massive surge in telemedicine, and now we are essentially facing a new digital revolution with new solutions. It's accelerating rapidly, and these solutions are highly decentralized. As someone involved in developing them, and we have a specialized unit in our center, I can say it's very easy, very accessible. Practically everyone can develop such solutions now. Now we have these technologies, the so-called vibe coding, where you simply write what needs to be done, and the neural network does it for you. Naturally, the real issue is what the final result will look like. You still need to understand programming a little. Nevertheless, it's becoming accessible, and this area will only become more accessible in the future. And then these digital entities, as they are called in various sociological theories, begin to embed themselves deeper and deeper into our digital reality, as Peter mentioned. They start to initiate certain social interactions and begin to alter existing social relationships. Therefore, there truly presents a major challenge for sociology to theoretically comprehend these new actors and, of course, integrate them efficiently and successfully into practice. This brings me to the second point, communication. We see that communications are transforming under the influence of digitalization, both within the healthcare system and the social sphere at large. In particular, classic top-down directive communications are becoming less and less effective. A few decades ago, health education could rely on direct instruction. Now that kind of directive messaging is increasingly ineffective. That kind of directive persuasion, practice a healthy lifestyle, don't smoke, don't drink, is no longer working. We need to find new ways to convince people to engage in proper self-preserving behavior. As a result, we are seeing new platforms emerge and the entire landscape of communication change, and we must also respond to this both theoretically and practically. And finally, the evolving social reality around us, both human and non-human, is generating new challenges for health, both physical and mental. It's no coincidence that Russia's new national project includes the word longevity. This really creates challenges for achieving longevity. In my presentation, I would like to focus on these challenges and what sociology can offer. Too often, both among the general public and even experts, sociology is reduced to just opinion polls. It practically becomes a synonym for them. But sociology is not limited to opinion polls. Sociology is a specific way of looking at the world. Although, indeed, from the standpoint of applied sociology, polls undoubtedly play a crucial role. First, we have sociological theory. Our task is to synthesize this theoretical knowledge into a coherent framework. I keep saying over and over that if we don't synthesize it into a coherent framework, it will be just a collection of separate bits of knowledge, and we won't be able to effectively explain what is happening or predict anything. The second area is of course, sociological research. But again, not just opinion polls. There are many different methods. New methods of digital sociology, like social media analytics, can also be brought into sociological research. This also includes various forms of participant observation, which don't even imply any studying. Naturally, all of this can help build balance between technology and humanity. Finally, there is a vital aspect more established abroad than here we should remember: sociology as a form of action. What I'm saying is, based on understanding of sociological theory and the research we conduct, sociology can develop specific recommendations recommendations. It can become both a source of recommendations and a kind of instrument for change. Now let me outline these three aspects briefly. The first one is theory. We genuinely need to find new theoretical frameworks that allow us to better explain our reality. Our research pays close attention to how this refraction or distortion, so to speak, happens. When we adopt certain laws, interventions, or standards at the macro level, then we survey people, we can see that at the level of everyday world of ordinary people, these macro level changes get refracted in very strange and unexpected ways. Sometimes they are adequately perceived, and sometimes they are significantly transformed. We need specific theoretical models to explain this phenomenon at all. In our research, we pay considerable attention to what we call social perception as a kind of intermediate transmission levels, what Lippmann called the pseudo-environment between the macro and micro levels. It's not enough to simply point out the concept of social perception and back it up with polling data. It's crucial to understand that social perception is highly complex and multifaceted. It has cognitive components, emotional components, conscious and unconscious aspects. It's multimodal, which means that we perceive information through different sensory modalities, which shape our understanding differently. Therefore, it's extremely important to reflect this complexity in our theoretical work as well and develop recommendations that actually work. And that was the theoretical aspect. Moving on to the second aspect is applied sociology or sociological research. Indeed, as our colleagues from Belarus have noted, we conduct both classical and digital research. It's important to acknowledge that despite ongoing debates, telephone polls remain the global standard for representative sociological research. There are solid reasons for this too. In my opinion, the simplest way to counter these misconceptions, which I still frequently hear from colleagues at conferences, for example, is by actually participating in polls like this. We primarily use classical methods to understand the landscape of change. For instance, our research this year focused on three key themes. The first one is, of course, AI in healthcare. In recent years, we have been actively studying public perception of AI. This past year, we have seen a sharp increase in the application of generative AI across virtually all sectors, not just healthcare. There was a certain plateau in the previous 2 years as people grew accustomed to the technology, but this year we've witnessed a real breakthrough. In our polls, people are more now reporting using AI for health-related queries. As many as 15% have even tried uploading some form of their personal data into systems to get the health-related answers from generative AI. However, as noted here and seen globally, distrust in AI for health still outweighs trust. People primarily trust medical professionals, not digital systems, although, of course, there are certain enthusiasts who are more receptive to AI. Moreover, indeed, some users are beginning to engage with AI almost as if it was another person. About 9% of respondents already attribute human traits to AI, and 15% do so partially. That means a quarter, to one degree or another, are already interacting with AI as if it were human. Next, the second theme we examined within this overview is longevity. Our approach defines longevity as lifelong health, which is the core idea of the national initiative. This means fostering health not just from birth, but from conception itself, building that foundation of health right from the start. And our data shows that people still tend to undervalue a role of mental and social well-being. As we know, health is a state of complete physical, mental, and social well-being. We observe that in people's immediate associations, health and longevity are primarily linked to physical health. This indicates room for growth, and it is very encouraging to see that more and more at experts' forums today issues of mental and social health are being raised. I believe that this trend will continue to strengthen. Of course, for many people, longevity is still something that applies mainly to the older generations. When we try to talk to people about longevity, they often say, Oh, you mean it's for seniors, especially young people? Clearly, there's room for improvement here as well. If we want people to see longevity as lifelong health, then this broad goal needs to be reframed in a way that resonates with individuals in their everyday lives. And the third area we worked on is infrastructural change. As I mentioned, directive communications are effective, but increasingly less so. Therefore, we need to create a certain infrastructural environment that nudges patients and people towards better self-preservation behavior. Here, we decided to look at this issue from the perspective of healthcare workers themselves. We developed a validated instrument to assess infrastructure precisely from the viewpoint of medical professionals, and we plan to continue scaling up this work. Alongside classical quantitative research, we, like our colleagues, continue to conduct qualitative studies. We have the classic methods, we run focus groups, in-depth interviews, and we also experiment with new approaches. Specifically, this year we have been more actively enjoying the method of autoethnography. We have colleagues in the audience who use this method, and they will be leading experts in this field speaking in the upcoming sessions as well. Moving on to digital sociology. This largely involves working with big streaming data. We can divide it into streaming data by people's behavior. This is data collected by state information systems and commercial platforms such as banks, mobile operators. We can genuinely conduct sociological analysis and draw sociological conclusions based on how people actually behave. One major benefit is that we bypass the self-reporting bias altogether. We aren't asking people what they do, we are directly observing their behavior, because there is often a significant gap between what people say and what they actually do. On the other hand, we severely lack data on motivation, which greatly complicates predicting human behavior. Therefore, the optimal path is indeed a combination of classical sociology and this more modern digital sociology. Then we need to talk about social media analytics. This is big data focused on digital communications, and here once again we address issues like brand building for digital organizations, services, and the overall brand of the healthcare system. This is, of course, a primary subject within the sphere. And finally, the third area. I believe it is the most important and promising one, only just emerging in both our country and abroad. This is the study of the so-called digital others. These are known by various terms. In classical theory, we would call them non-human actants. We have various understanding of what that entails. And these are AI agents that, to a certain degree, simulate human behavior. There is contemporary research suggesting that neural networks possess something akin to self-awareness, though it is still an approximation. It exists. Neural networks can already engage in a form of reflection. So what does this mean for us? Both businesses and large organizations are now actively developing the field of synthetic data. As of today, no one globally has achieved more than 85% success rate with it, and attempts to replicate known experience with this 85% benchmark have not been universally successful. Nevertheless, for specific tasks, these synthetic agents can already be configured in certain ways. The second area, which I see as more accessible for sociologists right now, is analyzing the internal logic of neural networks. This is not a philosophical question about the nature of a neural network's mind. It's a deeply practical one. Why? Because the way a neural network operates dictates how much it interacts with humans. And by influencing people, it inevitably transforms social relations. Therefore, it is critical for us to identify any overlooked ethical problems in the development of these networks, or any biases, whether conscious or unconscious, embedded within them that hinder their effective use, particularly in healthcare. For this purpose, we have developed specific procedures for a kind of sociological polls for neural networks. We can provide specific prompts or stimuli and then use defined methodology to analyze their responses. This allows us to determine, for example, whether outputs contains biases or stereotypes. I will delve into the specifics of this tomorrow when we discuss methodology for prompt-based experiments. Unfortunately, we don't have the time for this right now. So, what do we find now? We have various neural networks, and for each which we selected specific key medical stereotypes to examine how strongly they are represented in different models. We compared domestic neural networks with Chinese and American ones, observing how each of them performs. In particular, it was very interesting to find that neural networks of different modalities are indeed susceptible to different stereotypes. For example, when using computer vision, it tends to toward one set of biases, while textual neural network leans more towards other stereotypes. So the nature of the bias differs depending on the modality. Finally, the last area is sociology as action. Another classic approach that we are experimenting with is the use of opinion polls when we conduct interview-led surveys on health education topics. For example, when measuring health literacy, people often ask the interviewers what the correct answer is. Since we as researchers don't provide correct answers, we start noticing that interviewers often begin to improvise their own explanations. Obviously, interviewers are not medical professionals or health educators, but they sincerely want to help the respondent. They aim for trusting communication, and they try to explain things in their own terms. This seemed like an interesting direction for us, and at the very least, we could at least make sure that the interviewers refer people to verified information sources. And in the longer term, we are considering whether interviewers could indeed act as specific educators in this narrow fields. The second direction is the development of information system directories. In particular, we recently launched an information website for the specific foundation of healthy and happy longevity. This platform brings together our research and work of our colleagues on longevity. We frame it not solely as an issue for the elderly, but a matter of health across the entire human lifespan. It features studies from our country and international research. We're actively expanding this database. It is constantly updated. So make sure to visit this website. Another direction which we literally finished working on yesterday is the marketplace for the so-called synthetic workforce that I spoke about last year. These are digital solutions that accelerate and optimize our work as sociologists. This also created a new area for sociological inquiry, similar to user experience research. We're studying the interface itself because the so-called synthetic workforce shouldn't just be technically proficient or logically sound for research. They must also be user-friendly. This workforce needs to have a good, convenient interface. So that is all from me. Once again, I believe that the technical research is crucial. We are already past the point of no return with technology. We can debate whether this digital revolution will be transformative or not, but it will stay here for a long time. However, it's important not to forget the human element. Thank you, Ignat Viktorovich. But to conclude our plenary session, I would like to ask you a question. From your point of view, where does the balance between humanity and technology lie? And how should we measure it? Well, the balance between humanity and technology, I believe, is a fluid one. The most cutting-edge areas of sociology tell us that social reality is highly dynamic. We are constantly reconstructing it. Therefore, this balance cannot be frozen. It will be in constant flux for us. The challenge is simply not to define just this balance, because by the time we settle on an answer, social reality will already have moved on, and we will have to start the search for the answer all over again. The more pertinent question is, how do we capture this balance more swiftly? How do we produce a reflection on what the balance is approximately is now? How to avoid a significant lag? We don't want the studies relevant only to the early stages of the pandemic still coming out years after it's over. So really, it is about changing our approaches. And this is where digital sociology proves invaluable. With its dashboards and real-time online data, it's well suited for trend watching, for monitoring trending topics. I believe digital sociology offers the best chance to find this balance quickly, almost in real time, and to identify what adjustments we need to make to shift this balance in the right direction.
необходимо произвести, чтобы этот баланс двигался в нужную сторону.
Dear participants of this forum, this plenary session is now drawing to a close. However, we do have 3 more sections scheduled for today. Within this, we will discuss in detail the sociological tools that can be used to study the value of health, human attitudes towards technology, and, as strange as it may sound now, technology's attitude towards humans. And of course, we will also talk about the digital brand of the doctor and the medical organization, as this is becoming a key issue in healthcare system position. Tomorrow, we will look forward to welcoming you for the full day of practical case studies. They will be hosted on our digital platform called Moscow Healthcare. You will have the opportunity to explore the most successful, the best, the most effective sociological practices for studying healthcare systems, doctor-patient relationships, and of course, the healthcare system as a whole.